Good afternoon or good evening, wherever you are. I'm Dr. Seng Kyong Fang from Malaysia, and welcome to our 9th webinar for this year, entitled New Surgical Techniques in Glaucoma. And I will have with me Professor Do Tan from Vietnam as my co-chair. And first of all, I would like to thank Santen for sponsoring this webinar. Just a bit on our Asia Pacific Glaucoma Society. As you can see in this slide, these are the benefits that you have to join as a member. Mainly, you have a registration discount for the Asia Pacific Glaucoma Congress, and also access to the APGS educational online educational activities such as surgical videos, recorded webinar series, and the rest, as you can read in the slide. And also the QR code is there for you to scan if you want to join as a member. Can I have the next slide, please? So this slide just shows all the webinars that we have recorded. This is today is the 9th webinar already, and we have a series in the website that can be viewed by APGS members for free. And there are also other videos, educational videos on demand. Right now, I would like to hand over to Professor Do Tan to introduce our speakers and the topics that they will be presenting. We will have the first three pre-recorded speakers first, and then have a live Q&A with all the speakers. And then after that, during the second hour, we will start with the final two pre-recorded video presentation, and finally a live Q&A at the end. Over to you, Do Tan.
Thank you, SK, and hi everyone, good evening. And it's my pleasure today to introduce to you our 5 speakers on this webinar. So first of all, Dr. David Wu will speak on early intervention in surgical glaucoma, paradigm shift. And after that, we will hear from Professor Poemen Chan, who will speak on safe cataract surgery in glaucomatous eyes. That will be followed by Dr. Rahat Husain from Singapore, who will speak on the expanding role of SLT. And the two final speakers will be the Dr. Rainier, Covar, who will speak on the revision trabeculectomy practical consideration. And the final speaker will be Associate Professor Chelvin, who will speak on what new sub-conjunctival Bleb-forming innovations. So let's start our webinar.
Very good evening to everyone. The way we treat glaucoma is changing, and I would like to speak to you about surgery for glaucoma and how we may be heading towards earlier intervention. These are my financial disclosures. We all know that intraocular pressure is the only modifiable parameter in glaucoma management, and that lowering intraocular pressures reduce the risk of disease progression, and increasing intraocular pressures are correlated with an increase in the risk of progression. Two terms have been coined in the past with regards to IOP management: a reactive school of thought whereby the target IOPs are a little bit more modest and then adjusted according to deterioration patient visual function, and a more proactive school of thought whereby the IOPs are lowered more aggressively. And obviously both school of thoughts have their pros and cons. The traditional treatment paradigm for glaucoma, particularly, especially in this case for open-angle glaucoma, would be topical treatment, followed by more topical treatment until the patient reaches a state of maximal medical therapy, MMT, followed by traditional surgery, usually in the form of filtration surgery or a glaucoma drainage device tube. Topical treatment, as we know, has its own issues with compliance, a big problem, patients deviating and not complying with the treatment plan. Patients' quality of life is drastically reduced. We know that patients do not like to use eye drops. And over the duration of the patient's lifetime, the cumulative cost of eye drops are not small. The traditional operations for glaucoma have has historically been reserved as a last resort. This is because, especially for operations like filtration surgery, these are regarded as fairly high risk, with hypotony, wipeouts, infections among the things that keep glaucoma surgeons awake at night. To make it worse, these operations are usually done in advanced diseases where the patient's optic nerve reserve is already low, with the risk of wipeout. And for these operations, they can be a little bit unpredictable at times, even for an operation like the glaucoma drainage device, where flow can be controlled and hypotony can be minimized using external or internal ligatures. This is a case of someone who's had a barbell tube, someone with rubeotic glaucoma, who's had an intracameral restenting procedure. This is someone else who's had a retracted conjunctiva from a glaucoma drainage device needing resuturing in operating theaters. There is an argument for early surgical intervention. One can argue that proactively lowering the ocular pressure removes the responsibility of topical treatments from the patient, at least to a small extent, and therefore in part mitigates the compliance issues. One may also achieve lower intraocular pressures earlier with less fluctuations to the patient's IOP on a diurnal basis. And also patient's quality of life is improved with fewer or no drops and preservation of vision. The operation may also well be cost effective over the patient's lifetime if it stops them from needing eye drops for years. The evolving treatment paradigm mainly revolves around, for open-angle glaucoma, laser trabeculoplasty, which my colleague will be speaking about in shortly, and also microinvasive glaucoma surgery. We know that the microinvasive glaucoma procedures or minimally invasive glaucoma procedures are a collective term for many devices. These are short procedures under local anesthetic. They do lower the intraocular pressures pretty well, but not as well as the traditional operations. But they do offer a better risk profile because they are quicker to perform and also potentially fewer follow-up visits compared to, for example, a trabeculectomy. We're all aware of the different classes of mixed devices. Probably the most commonly used device is the iStent, which is a trabecular micro bypass device, and it has already gone through several versions, the G1, the G2, with two devices in each, two stents in each device, and also the G2W with a wider base, which is supposed to reduce the number of reduce the frequency of over implantation, which was a potential problem with the G2s. The iStent has a good body of evidence with regards to lowering ocular pressures and reducing dependence on medication, elegantly summarized by our colleagues in Singapore, and this body of evidence is growing by the day. Safety data is also pretty good, usually with malposition or high femurs, the most commonly encountered issues. These are usually minor and also uncommon. The other trabecular microbypass device is the Hydrus microstents, recently acquired by Alcon. This is an 8mm Schlimm's canal scaffold made of nickel titanium alloy, which sits in the Schlimm's canal. There is good data for lowering of the ocular pressures and also reducing topical medication reliance compared to cataract surgery alone, both in the Hydrus 2 and the Horizon study. Comparisons have been made to the G1 iStents, two of them, and the results seem to suggest that the Hydrus does lower pressures a little bit more. And studies have also been done versus SLT, again, which shows that the hydrus does lower the ocular pressures more than SLT, with also a greater reduction in topical treatments. Complications are uncommon with the hydrus, mainly, again, malposition, hyphema, and also transient intraocular pressure spikes. However, there are some question marks about endothelial cell loss, and this is uncertain over the long term and still subject to debate. Regardless, the UK National Institute for Health and Care Excellence have felt that the evidence is sufficient for them to make a recommendation that trabecular microbypass surgery is the evidence for trabecular microbypass is adequate in quality and quantity and may be used in open-angle glaucoma by suitably trained personnel. Subconjunctival mix, I will be speaking only very briefly about, because Professor Sung is going to be talking to you about the PreserFlow. The Zen implant was probably the first subconjunctival mix device. It was approved in 2016 by the FDA for open-angle glaucomas, pigment dispersion glaucomas, unresponsive to maximal medical therapy, and also refractory glaucoma with previous failed surgery. It also has European approval and can be combined with cataract surgery. As you know, there are two sort of methods currently with an ab interno or external approach. Bleb fibrosis is the biggest problem with the subconjunctival devices, with reported reported needling rates or revision rates for the Zen implant up to about 46.2%, and about 40% needing more than one needling in the first 24 months. One can encounter hypotony with these Zen implants, but these are usually self-limiting. Late erosions are another possibility which may require revision. The UK National Institute for Health and Care Excellence a little bit guarded in terms of the quality and quantity of the research and evidence, and there are certain conditions that they have suggested that clinicians adhere to, but the Zen implants again are fairly widely used. Finally, lens extraction for primary angle closure glaucoma. Let's not forget what might well be the most commonly performed procedure for glaucoma, which is cataract surgery, following the EAGLE study, which shows that for patients with clear lenses and ocular pressures of 30 and above, and also primary angle closure glaucoma, then removing the lens itself, i.e. cataract surgery, may well be more efficacious than performing peripheral iridotomies. So in terms of cataract surgery, we may well be shifting to, or we already are shifting to, very early cataract extractions for primary angle closure glaucoma patients. So just to summarize, the glaucoma treatment paradigm is definitely changing. And with the greater variety currently of surgical options available now to us with good safety profiles, it may well be time to switch from a traditional reactive mode for managing someone's intraocular pressures to perhaps a more proactive approach with all these new options at our disposal. Yes, these devices may not lower the ocular pressures as much as traditional surgery, but this may well be sufficient to prevent the patient from progressing. I understand questions will come later on, so I'd like to hand this session back to the host. Thank you.
Hello, I'm Poemen Chan from Hong Kong. My topic today is cataract surgery and glaucomatous eye. These are my financial disclosure. We tend to be careful when dealing with phaco for eyes with glaucoma because we worry about wipeout syndrome, especially for advanced stage glaucoma. Therefore, we pay particular attention in the intraocular pressure control before, during, and after the surgery. As far as intraocular pressure control is concerned, phaco reduces IOP in angle closure glaucoma. During the operation, we should also be careful about IOP spike and the possible effect of existing bleb and also the tube shunt due to inflammation. Some of these eyes are surgically challenging, and we should take precaution to avoid complication because that means a longer operating time and more manipulation, which increases the risk of wipeout syndrome. The combined procedure part are beyond the scope of this talk. So we will talk about wipeout syndrome and intraocular pressure. Now, before we do surgery, we have to make sure that the cataract is justified. The cataract surgery is justified for the purpose. Certainly, we extract the lens if the cataract is significantly affecting the visual acuity. Experience tells us that phaco may help sustainably lower the IOP for POAG. However, the current evidence is probably not justified if we are to do the phaco purely for the sake of lowering the pressure. For PACG and PAC, yes, probably killing two birds with one stone in case of cataract. For clear lens, we have to be more careful and not just doing the phaco because EGO study demonstrate the effectiveness. Remember that there is always a risk of surgery, and the EGO study have a strict recruitment criteria, including patients with age more than 50, willing patients, PAC with IOP more than 30 millimeters mercury, and also mild to moderate PACG. We might have to consider other approaches when dealing with other types of patients with angle closure. There are also other considerations, depends on the patient's conditions. We know that wipeout syndrome is related to IOP. Now, during phaco, the IOP could be markedly elevated, as demonstrated that IOP could rise up to 11 millimeters mercury for every 15 cm bottle height above the operating eye. So for a bottle height at 1 meter, you're talking about an IOP more than approximately 70 millimeters mercury. Wipeout syndrome can lead to severe visual loss, as I said, especially for advanced stage glaucoma. Now, shortly after phaco, there's a risk of IOP spike. It is particularly risky for eyes with retained viscoelastic, prolonged surgery, retained lens matter, iris pigment, inflammation, and also hyphema. Other risk factors include PCR, vitreous prolapse, placement of sulcus IOL, pseudoexfoliation, etc., as listed here. These are the preoperative measures that could lower the risk of IOP spike. So topical and systemic medications, if there is a Bleb or tube shunt, you may consider combining with needling, depends on the Bleb status and also preoperative IOP. Inflammation control is important, especially with uveitis. Carefully check the corneal status. You might want to improve the ocular surface status for patients with ocular surface disease, and also to give you a better surgical view, and also specular microscopy to check the endothelial status, and also check the lens angle status, pupil size carefully so that you can plan ahead. Early postoperative period, you can give oral acetazolamide and topical medications to limit the chance of IOP spike. Perform AC paracentesis promptly in case of elevated IOP. Also consider steroid-induced IOP spike in late postoperative period. Talking about intraoperative precautions, my principle is to have a minimal manipulations under low IOP condition, ensure patient's cooperation, and also avoid iris prolapse. Because that increased to ensure the patient cooperation and avoid iris prolapse, because that increased the inflammation and leads to hemorrhage, iridodialysis, if not careful, and prolong the operating time. So for me, a small volume of retrobulbar anesthesia actually helps to stabilize the eye, and also should be acceptable. I tend to combine with topical anesthesia as well, just to make sure patient is comfortable. Of course, it is best to do under general anesthesia if possible. Other intraoperative measures are based on my principle to avoid IOP spike. So these include a 3-step wound. This is self-sealing, low bottle height, modest use of viscoelastic. Very tempting, by the way, to over-inject viscoelastic for young surgeons dealing with shallow anterior chamber. Also, very tempting to push open some synechia by injecting some more viscoelastic towards that synechia. I tend to use as much mechanical means to do the synechia lysis as I could, and avoid to open up long-standing anterior synechia that looks unlikely to help the pressure control. Good pupil dilation is important. I now have a very low threshold of using iris hook, soft shell technique to protect endothelium, avoid retention of viscoelastic and lens matter, and also subtenon injection of steroids for inflamed eye if not contraindicated. Here's the list of the risk factors that could lead to IOP spike and my strategies to overcome them. One of the important things is to try to avoid iris prolapse. So I do a 3-step corneal wound and avoid injecting too much viscoelastic. If there's iris prolapse, again, try to use minimal maneuvers to resolve it. Avoid using the cannula tips to push the iris. that traumatize the iris and makes it easier to prolapse again. So I use iris repositor, may egress some of the excessive helon in the AC to lower the pressure, and sometimes I inject some helon 5 to compress on the iris because it tends to stay in the AC, and use the iris hook to stabilize the iris if necessary. This is the configuration of my 3-step corneal wound. It's self-sealing. I used to have iris prolapse rather often when I was a young fellow, and I once thought that because I had difficult cases. Now with this 3-step wound nowadays, I rarely have iris prolapse. Notice that the wound constructions naturally place the internal entry site more anteriorly. These are some of the considerations of cataract surgery, especially for pseudoexfoliation and angle closure. Now, so pseudoexfoliations are mainly about the small pupil sonular instability and also the post-op IOP spike. For angle closure, apart from the obvious one as listed here, there is actually a slightly higher risk of a radial tear during the capsulesis because you are trying to do a capsulesis on a steep anterior lens surface. So sometimes a force slide to the side and causing a radial tear. Now let me show you some of the bad examples. Many years ago, I forcefully tried to inject the IOL into the bag when the eye wasn't terribly ready. This is a patient for angle closure, so I end up have to try to inject some viscoelastic into the bag by having the cannula going behind the IOL, as you can see here. More injections, as you will notice. You see the back is forming again. Quite a bit of pressure, so I stopped there. What I have to do is to put the instrument behind the IOL and try to put the capsular tension ring in the capsule. I tend to use this way to put the capsular tension ring by hooking the one end of the CTL with the Sinskey hook and carry on injecting. This way, you have less stress on the capsule, which really helps. Otherwise, you would tend to apply too much pressure on the capsule, which I worries about. Now the part of the lens, the haptic is still in the AC, so I use a Coogan's hook to manipulate the haptics back into the bag. So this is one of the very bad examples of me not taking care of the eye. There we go. We slide the haptic back into the bag. And fortunately for this patient, we don't have much vitreous loss. So centralize it. The bag was intact. Scalable, I checked, double check whether there's any vitreous. There's none. So I carry on and make sure that I do a thorough aspiration. Pupil was round. Then another bad examples of me trying to forcefully inject IOL into the bag. That was done many years ago when I was a young fellow. Pupil was small. I have to dissect the pupil with the mechanically with the Coogan's hook, and I fast forward a little bit for the phaco part. Stretch the pupil. The pupil was big enough, so I carry on ambitiously. Just a bit of difficulties, in fact, quite shallow. At least was very, very shallow for me as a newly trained surgeon. Phaco, more phaco. Eventually, everything is cleared with the cortex removed. I try to blow up the bag. You can notice that there's some iris prolapse, and also the pressure is quite high. Lots of vitreous pressure. I found it difficult to, as you can, but I wasn't aware. I forcefully tried to inject the IOL, and as you can see you can note, you might appreciate that's quite a high vitreous pressure during the procedure. Try to forcefully push the lens in, and then I realized that I actually ruptured the PC. I couldn't quite show very well here. So what I do is I have to raise the IOL and hopefully remove it, so that because I know that now I have to put in a sulcus IOL, and really a one piece putting into a sulcus is not a very good idea. That increases inflammation, so I have to put the lens back in. I got one of the haptic in the AC now. I try to rotate the other one to the AC. A little bit of viscoelastic. I think for this case, I'll inject a little bit too much, and put the haptic back in to the AC. Great lesson to learn, by the way. I try not to forcefully inject the IOL into the back anymore. That's called trying your luck, really. And I think mentally, if you try your luck, you're bound to fail for glaucoma patients. So try not to do that. So I have to do an IOL exchange, remove the intraocular lens, hold on to it. I was very worried about dropping the IOL. Remove that first piece, and I didn't quite get it. I got the second piece, but didn't quite show in this video. So do more vitrectomy, a thorough vitrectomy, and then I enlarged the wound. Enlarged the wound a little more, and I placed the 3-piece MA lens into the sulcus. Struggled a little bit, so I have to put the haptic back in. Again, I try to put in, but inexperienced, so I end up putting it in an angle. I have to make sure that the haptic is back into the sulcus. So I use a bimanual technique again. So that's it. Great lesson to learn. This phaco, I realized that there's some phacokinesis in the middle when I was doing the self-tilting. So I put in an iris hook. I hook on one side. I thought it's going to be okay. That stabilizes the capsule. Again, this was when I was a young fellow, quite scary at the time. So I have to carry on with the phaco. Young fellow in a disaster kind of procedure, you tend to get lazy. I just put in 2 hooks, and I should have put in more. As you can see that in the middle of the procedure, when I was doing a phaco, I realized hang on again, the back is not terribly stable. I was a little bit concerned. So what happens is, as you will realize, I have to stop and put in some viscoelastic to stabilize the AC. Still not learning, so I carry on. And then eventually I realized that I have to stop and put in more more ring, more iris hook to stabilize the capsule again. I'll skip one of these, and I then put in a capsular tension ring first because it's not stable. That's the time when I didn't use that bimanual technique. You can see that there's a lot of stress on the capsule. Not good. Remove the rest of the hedon, the lens matter. Insert the intraocular lens, and I try to I removed all the iris hook, and then I realized that in fact, even with the there's still some iris products after closing the wound. Then I realized that there is a lot of vitreous there. So what I did, instead of using a vitrectomy, I inject the. You can see that what I did is to use an intraocular lens, intraocular scissors. I used the Velon to group the vitreous together. Use a Velon so it cuts the vitreous away. And after the cutting, the pupils get round. Right, just to do a second cut and the pupil was round, so that was okay. So these are the references, and thank you for your attention.
I'd like to start by thanking the Asia Pacific Glaucoma Society and Santen for inviting me to give this talk on SLT. I have no financial interest to declare that have relevance to this topic. So I'm going to start by describing what is SLT and how does it work, and then I'm going to go through a series of questions that I myself ask when I'm considering giving SLT to my patients. These are, as you can see, how efficacious is it? Can it be repeated? What are the complications? What settings should I use? How to select my patients? And are there any predictors of success? So first of all, what is SLT? Well, this was described in 1995 by Latina and Park, and it is a 532 nanometer Q-switch frequency doubled ND YAG laser, which is applied to the trabecular meshwork with a 400 micrometer spot size. The duration is 3 nanoseconds, and this is important because it's shorter than the thermal relaxation time for melanin, and therefore the heat is not dissipated to surrounding tissues as opposed to ALT. And this applies the principle of photothermolysis, which was described in 1983. There's a biological mechanism of action which results in an increased outflow facility. For those of you who are interested to learn more about this, there's a nice review article published in 2014, as you can see here. This is a well-known picture of a patient's trabecular meshwork electron micrograph. On this side you can see they've had ALT, and on this side SLT. So it's quite clear the amount of damage to the surrounding structures is less than in SLT. But it's incorrect to think that there's no damage at all, because there's thought to be some, but more on an intracellular level, and certainly less than ALT. In terms of its efficacy compared to medication, there have been 3 meta-analyses performed, 2 in 2015 and 1 just last year, and they all show that both SLT and topical medication just demonstrate similar success rates in terms of IOP lowering in patients with open-angle glaucoma. So I'm going to spend the next few slides talking about the landmark LIGHT trial, which was a well-designed study comparing SLT to medication for first-line treatment of patients with ocular hypertension and glaucoma, with a large number of patients and good follow-up. And this was published in the Lancet in 2019. The main outcome measure was health-related quality of life, as measured by the EQ5D5L utility score at 3 years. You can see the inclusion and exclusion criteria here. I'll just draw your attention to the fact that there were no secondary glaucomas or angle closures included, and also excluded were patients on previous treatment. So these patients, there were over 16,000 assessed and 718 randomized, as you can see here, and they were followed up for 3 years. In terms of the target IOP and escalation criteria, these were defined based on the disease severity, as you can see in this table here. And for the SLT group, they were allowed to have repeat SLT before going on to medication if their target IOP was not met. And the process was the same as per the medication group, as you can see here, prostaglandins and beta blockers, etc. In terms of the results, the majority of patients had ocular hypertension or mild open-angle glaucoma, so that's worth remembering. There was no difference in terms of the quality of life measures between the SLT and medication group. There was only 1 patient in the SLT group that had an IOP rise that needed treatment, and there were no IOP spikes more than 10 millimeters of mercury. In terms of the percentage of visits at the target IOP, there was no difference between the 2 groups, as can be expected because of the way that the trial was designed. It's good to note that 78% of patients in the SLT group were medication-free at 3 years and at their target IOP, compared to just 3% in the DROPS group. Also interesting is that there were no patients in the SLT group that progressed to trabeculectomy, and there were 11 in the DROP groups, and this was significant. There's also some preliminary 6-year data available, not being published yet, which show this trend appears to continue. Some of the take-home messages from the LIGHT trial is that SLT should be performed for patients with POAG as a first line for treatment-naive patients. But there are some caveats. Should we be performing SLT for patients with ocular hypertension? Well, I would argue that there are many patients with ocular hypertension that do not progress to any disease status, and therefore it may be appropriate to just monitor these patients rather than applying SLT. Are the findings applicable to Asians? Well, we don't know, and so the LIGHT in China study is recruiting at the moment, and this is based on the same criteria as to the original LIGHT trial, and that will help answer that question, which is of particular relevance, I think, to this audience today. And finally, we have to remember that this was a study, and do the findings apply to the real world? Well, this was a study published just last year from the UK, where it looked at the real-world outcomes of SLT, which was a retrospective study of over 800 eyes, and they found only 18% success rate at 3 years. So why are these worse compared to the LIGHT study? Well, there are a number of possibilities, and which were mentioned by the author of this study. First, the fact is that there were many patients who were not on any drops. There were less treatment-naive patients, and this could indeed affect the outcome. In the real world, there were patients with comorbidities, which can also affect may have some effect on the efficacy of SLT. And if you remember, for the LIGHT study, the way they designed the target IOP was that if there was no evidence of disease deterioration, the protocol allowed the target IOP to be increased. So given the fact that most of the patients had ocular hypertension or mild glaucoma, it's quite possible that they didn't progress, and therefore their target IOPs were revised to be less stringent. So that might explain why this real-world study showed that it worked less well than in the LIGHT study. So it's just a word of caution, I think, when we shouldn't over-promise results to our patients because of those LIGHT data. So can SLT be repeated? Well, the LIGHT study did look at that, and they found that repeat SLT was able to maintain drop-free IOP control in 2/3 of patients at 18 months. There's been 2 other studies which have looked at that, at least two other studies. In Avery studies of 2013, it also found about 2/3 of the patients were able to have their IOP controlled, whereas in Hong's study, the success rate was less, around about just over 40% at 5 to 8 months. But one has to remember that in the Avery study, these were newly diagnosed POAG patients, whereas in the Hong study, there were patients who were already on drops. So the take-home message is that yes, it can be repeated, but one just has to take note of the fact that the efficacy may not be as good once SLT is repeated. In terms of the complications and side effects, this is taken from a review performed by Song et al. In 2006, and it shows that the 4 most common side effects are an IOP spike, anterior chamber inflammation, pain or discomfort, and peripheral anterior synecdoche formation. IOP spikes are quite rare, about 1 in 20, but it's more likely if the trabecular meshwork is heavily pigmented, as in pigment dispersion syndrome, for example, and therefore pre-laser IOP lowering drops are recommended. The inflammation tends to be common, but is transient and self-resolving. There do appear to be some corneal changes, certainly on specular microscopy. There's some studies to show that. And very rarely there's been some case reports of permanent scarring on the cornea, although thankfully these are very rare. In terms of the settings, there's some debate as to whether to do 180 or 360 degrees. There's been 3 RCTs which have compared 180 to 360, and 2 found that the results were the same, and the third showed that 360 did appear to get better results in terms of IOP lowering, but this was at the cost of more symptoms. It's best to start low and then titrate upwards in terms of the power until you see a little bubble, and then decrease a little bit. And most people tend to start at about 0.8 millijoules. You should give about 50 to 100 shots and use the Latina lens, which is a no magnification lens. And most people will give an alpha-2 agonist either before or just after the laser. Some people can give pilocarpine 2% just before the laser. This has the added advantage of opening the angle up a little bit more, so it may be a bit easier to perform the SLT. It's best to check the pressure 30 minutes to 2 hours afterwards. Post-op drops is debatable. There's been 3 RCT comparing NSAIDs, steroids, and no treatment, and they found actually it didn't show any difference in terms of its effectiveness. There is one study, the SALT trial, published a couple of years ago, which suggested that this was a study of 96 patients, and it suggested that giving steroids after SLT was associated with better IOP control at 3 months, which is why some people still give post-laser drops. It's best to review the patients at about 2 months. In the LIGHT trial, they reviewed patients at 2 weeks as well, but they found that there were no patients that needed any intervention, and therefore they concluded that the 2-week review is not necessary. As I mentioned before, SLT does cause some damage to the trabecular meshwork, although less than ALT. And there's some data to suggest that giving low energy SLT, about 0.4 millijoules, with less shots, might be more effective than higher levels. And this is based on a presentation in ARVO 2018. And therefore, this COAST trial has been designed to try and evaluate whether regular, for example, yearly low-level SLT might be better in order to maintain good pressures compared to the PRN nature of SLT, which we tend to do at the moment. So I think this will be quite interesting when those results come out. In terms of the patient selection, typically we do this on patients with POAG or OHT. One can do it in patients with PACG. There does appear to be some benefit, but it depends on the amount of angle opening. This was a study published in Singapore in 2015, which showed it appears to be effective over the short term, although there were some concerns about its effect on the corneal endothelium. It can also be done in patients in NTG, and this is a study from Hong Kong, which showed that after 2 years there was some benefit in terms of IOP lowering, although of course one has to be aware that there is going to be a limit as to how low we can get the pressure due to the episcleral limitations. In patients with uveitic, silicone oil, post-trabeculectomy, there's not much data there, but generally it's thought to be some benefit. This was a study published only on 16 patients who have had post-trabeculectomy SLT, and it showed good success rates. It also works for patients who are younger, and this was published by Liu et al. In 2020. And I think this is particularly encouraging for our patients who might be pregnant, female patients, and in whom you're reluctant to start or continue drops. It appears that giving SLT for this group of patients would have some benefits. Most studies show that having a higher pre-laser IOP is a good predictor of success, although this may just be a reflection of the definitions of success, which is generally percentage-based. The LIGHT study showed that success at 2 months was predictive of success at 3 years. Previous drop use, it appears that it's effective, but perhaps less so than in patients who are treatment naive. In this study from Hong Kong of just over 50 patients, they found that even being on up to 4 drops you can get a successful result in SLT compared to patients on less drops. And in this study of over 200 patients from Australia showed some similar findings, and when they looked at the number of drops, patients on different numbers of drops, although they found that the more drops you were on, the more likely you were to need trabeculectomy. I will just finish off by describing some other modalities of delivering the SLT. You have the micropulse diode, which is thought to cause less inflammation, the titanium sapphire, which is thought to penetrate deep into the trabecular meshwork. One can also use the Pascal, which may save a little bit of time. And I think this is quite interesting, the direct selective laser trabeculectomy, because this is non-contact. This was described in 2017. Just takes 2 seconds, and the Glorious trial was designed to compare this DSLT to traditional SLT, and 6 months results are expected in a few months' time, and that will be very interesting because that could be a game changer. So in summary, SLT ought to be given strong consideration as a first-line treatment for newly diagnosed treatment-naive patients with POAG. It appears to be safe, It can also be used on patients with secondary glaucoma and on those with current medications who develop side effects, but it's probably less effective in this group. The optimal energy settings are still to be determined, but it can be repeated, and post-laser drops are probably not necessary. Watch out for the COAST, Glorious and Light trial results, because I think those will be very useful for us. Thank you.
Thank you, David, Poemen and Rahat for an excellent presentation. We do have all our speakers with us now for the live Q&A. We have a question for David. The question is, why aren't more glaucoma surgeons doing early surgical intervention given its advantages, and what are the disadvantages? David?
Thank you for the question. I think with any paradigm shift, particularly if the established practices have been in place for so long, it takes time for practices to change according to best evidence. I think it can best be split up into surgeon and patient factors. So if you've got very established surgeons with their preferred practices, it can sometimes be hard to make people or convince people to change their mind. A lot of them will be maybe adopting a wait and see approach, waiting for more evidence to evolve. Some of them may have, for example, a particular type of practice where they receive a lot of referrals from VR surgeons, mainly with secondary advanced glaucomas, where they go straight for traditional surgery. I think with regards to patient factors, particularly for private practice settings, for example, the financial implications for patients are huge for early surgical intervention. For example, phaco eye stents are triple the cost of a monofocal phaco lens in Malaysia, thereabouts. So patients might well be just happy forking out every month for the eye drops. And maybe finally, cultural. So what I've noticed since coming back to Asia was that particularly for the elderly Asian patients, surgery is often seen as a huge problem. There is a problem and they are in trouble. It gets them very worried. And therefore, they might want to avoid surgery at all costs. And also, particularly for glaucoma, where you're trying to persuade patients that they're actually needing treatment, even though they don't realize they have an issue, they might not see any problems. Convincing them to use eye drops, that's hard enough. Convincing them to go for early surgery, that's going to be even tougher. I think it will happen. It will take time. So the obvious disadvantages are probably financial, and also obviously the surgical complications that may arise from it.
Thanks, David. Maybe Chelvin, you have a lot of experience with MIGS. You want to comment on this question?
Well, thank you very much, Dr. Fang. I agree completely with David that a lot of it's a mindset change. And indeed, I think a lot of surgeons may be risk adverse. And even though some of the procedures are quite safe, there's still maybe a little bit of increased risk due to implant malposition, which they may find not acceptable, but it's actually easily addressed. Cost is an issue, and I think that will be something that gets better with time, especially when there's greater volume of these devices being sold. Then it will make sense for the companies to lower the price of these devices as well.
Thanks, Chelvin. We do have quite a number of questions. There are two questions to Rahat. Rahat, some papers reported PG analogs may reduce the efficacy of SLT. Do you notice this in your clinical practice?
Yeah, I've spread those reports as well. I can't say I've noticed it particularly, but you know, there's so many factors, you know, depending on how many drops they're on, the patient's eye. So I guess it's something that you need to be aware of, but it's not something I've noticed particularly in my practice.
Sorry, Rahat, could I just ask you, if let's say a patient's on one drop of prostaglandin analog, and based on these reports, would you suggest stopping it and washing out the PG analog and switching to another drug in the meantime to give a better effectiveness of the SLT?
Well, I mean, not a bad idea, Chelvin, but I'm just not sure the evidence out there is good enough. And I know that there's certainly at least one paper to show that prostaglandin use does not affect the efficacy of SLT. So I must say, I probably wouldn't do that unless there's a particular, request from the patient.
Thank you.
Yeah, David has done a lot of SLT as well. David, do you want to comment on this question? You're muted, David.
Sorry, could you mind repeating the question again, please?
Some papers reported that prostaglandin analogs reduce efficacy of SLT.
I haven't really noticed any reduction in efficacy for, obviously, patients who've had eye drops for a long time. I do advise them that it may not work as well as treatment-naive patients, but personally, I haven't really noticed a big difference myself.
Thanks, David. Another question for Rahat also. How many times can you repeat the SLT? And if it's not working anymore, would incisional surgery be the next option?
Yes, it could well be. I mean, in the light trial, they repeated it once, and it showed that it did work. I guess if you can carry on repeating it, and if it's effective, then why not? Because the damage is quite minimal. I think that COAST trial, which I mentioned earlier, would be very interesting to see if low dose regular SLT is going to keep those pressures low. And so rather than sort of waiting till the pressure goes up, just continually to repeat it. But the evidence out there is not strong at the moment. So we'll wait for the results of that trial.
Yeah, there are more questions for you, Rahat. So many questions on SLT. How effective is SLT in highly pigmented trabecular meshwork? And how do you follow up patients since SLT can lose its efficacy?
Yeah, so it depends on the severity of the disease regarding how often you follow them up. So I tend to see them at about 2 months. And in terms of the pigmentation thing, so it's thought that perhaps with the more pigmentation, it may be more effective. And one interesting thing I found, because I used to work in England where we had a big Afro-Caribbean population, black patients. And I found in terms of the discomfort that they used to feel, it was more. So when I do it in Singapore, I find they don't complain of pain much. But in the Afro-Caribbean population, as opposed to the Caucasian population, it was, they definitely felt it more. So that's an interesting note from the pigmentation point of view.
And one last question for Rahat. Are steroid or NSAIDs drops after SLT effective for corneal damage?
Well, I think the corneal damage issue is there's not strong evidence for that, actually. So most studies show that actually the cornea is fine. And most studies have, when they looked at, there were 3 RCTs which compared steroids, NSAIDs, and no drops. And in terms of IOP control, it was fine. I don't think they compared steroids versus NSAIDs specifically in terms of the corneal effect on the cornea. So I personally don't give drops. So I think what the light investigators did is they gave some Acular to be used PRN if the patient felt discomfort. So I think that's quite a reasonable sort of approach to it. Okay,
thanks, Rahat. The next question from the audience is, what is the rate of endophthalmitis post-Zen insertion? Perhaps I would ask Chelvin. You have done, I think, a lot of Zen. So far, I haven't seen one, in my hands, but you want to answer, Chelvin?
Well, thank you, Dr. Fang. I think that a Bleb-related infection is possible after any Bleb-forming procedures and depends on whether the Bleb is ischemic or whether it's anterior. And in our phase 4 study, out of 200 patients, we had 1 case of endophthalmitis. So I think it's not common, but it does occur. It can be reduced though if there is, for example, if you do an ab external Zen and you make sure the mitomycin C is placed underneath the tenons and more posteriorly.
Okay. Anyone want to answer this as well? Poemen, Rainier, do you have experience with the Zen?
Well, some, not as much as Chelvin and all of you. Well, I haven't had a case of endophthalmitis yet, fortunately. So, but I suppose because of the more posterior positioning, the rate is probably lower. But sometimes I always concerned about, if there happens to be a blebitis, it can move into endophthalmitis rather quickly because you got a tube basically penetrating the globe. So that's something I will be quite worried about.
Yeah, Rainier?
I think I actually see a lot of cases referred for Zen if they're placed in the wrong position. So if you have Zens protruding out of a conjunctiva, or you get Zen exposed through the conjunctiva for some reason. So the malposition of these Zen devices, if improperly placed, can actually do cause some form of blebitis or some form of irritation in the conjunctiva. It thins out the conjunctiva and eventually may lead to some form of infection. But I have to say, I haven't actually seen one that actually became a full-blown infection so far.
Thanks. Dotan, you have any questions for the speakers?
Yes. Because I'm very interested in the presentation of Poemen, so can I ask you two questions? The first
Please.
one is which local anesthesia you prefer to do in glaucomatous eye when you do a cataract? Because some said that you should do the retro bamboo anesthesia because you use less lidocaine and you less chance to increase up the IOP during the surgery. So which one, or peribulbar or retrobulbar?
I actually go for retrobulbar because I know it sounds horrifying because you might put the pressure on the nerve, but I usually just inject one mil or 1.5 mil, combine that with a topical, because the patient usually have rather bad ocular surface disease, and I use a combined method so that it's smoothing out things, and usually works quite well, and that immobilizes the eye as well. They tend to move a lot, and you want minimum amount of movement during the surgery. Otherwise, you end up having all sorts of iris prolapse. We don't have that much general anesthesia session in my hospital, so I have to live with that.
So do you have the feeling that you are a little bit unstable doing phaco with retrobulbar because of the movement of the eyelids? Because the patient can open and close the eyelids.
Usually, I find that usually the speculum works pretty well. As long as they just don't move the globe, I think it's usually is fine for me.
Okay. So second question is about the anterior vitrectomy. You use some triamcinolone to color to mark the vitreous in the anterior chamber?
Yeah, I never use that. I saw it might be because of an early trauma in my experience, because I saw a senior using it, and the patient was steroid sensitive, and here now and then I never actually use the triamcinolone. So no, I don't.
Because that sometimes you did the surgery very well, you very confident, but the next day you see the pupil is just have the vitreous strand, and the pupil is not brown, and it is look not so beautiful.
Yeah. Yes, I think there is an advantage of using triamcinolone. I'm just really skeptical about triamcinolone after seeing that case, because that was quite a refractory glaucoma case. So so every time when something happens like that to me, I tend to be very, very careful with you cross-check all the vitreous, whether it's there or not, and make sure that the pupil is constricted so that it's all round, and making sure there's no vitreous in the AC.
Thanks, Poemen. One more question to you, Poemen. When do you consider doing phaco combined with filtering surgery? I mean, what are your indications?
Usually, 2 to 3 medications, and when the pressure is marching on 20 odd, And also patients with moderate and severe glaucoma, I will consider doing that. But obviously I have to talk to my patients and make sure they're happy about that.
Yeah. Okay, I think we have only about 30 seconds left. We will close this live Q&A session and then proceed to the presentation by Rainier and Chelvin, and then we'll have questions again at the end.
Good evening. Thank you to the Asia Pacific Glaucoma Society for inviting me for tonight's webinar. I am Rainier Covar, and tonight I'll be talking about revision trabeculectomy practical considerations. These are my disclosures. The first three speakers talked about using topical medications, doing SLT, and performing cataract surgery to decrease IOP. Glaucoma surgery is effective in lowering IOP in eyes wherein topical medication and or lasers have failed to do so or deemed unlikely to provide satisfactory IOP control. There are different types of glaucoma surgery for different types of glaucoma. It is thus very important to determine what type of glaucoma a patient has to be able to advise the proper glaucoma surgery for a patient. The most popular type of glaucoma surgery is trabeculectomy. It was developed in the 1960s, and here we make a superficial scleral flap as a resistance to aqueous outflow. In the 1980s, we started using 5-FU and mitomycin C to prevent scarring of these fibroblasts. Pictures below are electron micrography of fibroblasts treated with NSS and mitomycin C. The picture on the left shows spindle-shaped fibroblasts, while the picture on the right shows an elevated apoptotic fibroblast. In 2003, the Moorfield Safe Surgery System was developed. Here, they prevented the development of a ring of steel over our trabeculectomy area. They advocated making an incision at the limbal area, making a posterior dissection to promote posterior drainage, and having a larger area for application of our antimetabolites. In this paper, it was shown that trabeculectomy can improve long-term visual function in glaucoma. Their study showed that trabeculectomy slows the rate of perimetric decay and provides evidence of sustained long-term improvement of visual function in glaucoma. These findings suggest the possibility of reversal of glaucomatous dysfunction of retinal ganglion cells and their central projections. However, even in the best of hands, failed trabeculectomy occurs. Trabeculectomy success rates vary with the type of antifibrotic therapy used, but the rate of failure has been reported to be as high as 23 to 51% at 5 years and 52 to 59% at around 15 years. So how do we proceed? Just like any medical condition, we have to go to the root of the problem. We do repeat trabeculectomies or Bleb revisions in patients with high IOP due to plug sclerostomy, tight sutures, early Bleb failure, and rarely due to aqueous misdirection. But sometimes, we may have to do Bleb revision in patients with low IOP or hypotony due to conjunctival leaks, overfiltering blebs, choroidal detachment, and in some uveitic patients, they may have ciliary shutdown. Bleb morphology is an important determinant for the long-term success of trabeculectomy. It is important to assess Bleb morphology and function on every follow-up to recognize any undesirable patterns of healing in Bleb tissues to enable early post-operative interventions and to achieve better surgical outcomes. In patients with high IOP with deep anterior chambers, we must perform gonioscopy to check for any obstructions. The obstruction with fibrin and blood is transient, whereas obstruction with iris and vitreous needs to be surgically operated on. If the obstruction in the sclerostomy is ruled out, then high IOP is most likely due to tight flap closure. In these cases, we can do digital pressure or massage. We can remove a suture by removing reusable sutures. As in this video, we can loosen adjustable sutures, or we may perform laser suture lysis. If the bleb remains flat with high IOP despite massage and release of sutures, we should entertain the idea of early bleb scarring. We may perform needling with 5-FU or mitomycin C using a gauge 30 needle, and then breaking as much scar as we can, and then injecting the antimetabolite. Rarely, aqueous misdirection may happen, and in these cases, we should rule out overfiltration or wound leak, rule out choroidal hemorrhage or effusion, rule out pupillary block, and if we are convinced of such condition, we can initially manage this medically. We may perform a YAG hyaloidotomy in pseudophakic cases. We may perform a Chandler procedure, and if all these therapies does not work, we may refer our patient to our friendly retina specialist for a corvitrectomy. We now move on to hypotony. Statistical hypotony is defined as having an IOP of less than 6.5 millimeters mercury. However, clinically significant hypotony is a condition where the IOP is low enough to result in visual field loss. Sometimes we see patients in the 8 to 10 millimeter mercury mark, and yet they develop some form of maculopathy. On the other end, we see patients on the 0 to 4 millimeter IOP mark, and yet they can see very well, and there's no maculopathy or choroidal detachments. It is thus very important to determine what the clinical condition of a patient is rather than just measuring their IOP. With the advent of antimetabolites, we see a lot more conjunctival leaks in some of our trabeculectomy patients. It is thus very important to be able to make sure that we suture the edges of our conjunctiva very well to the limbus, and at the same time be very cautious on our application of antimetabolites and preventing the edges of our incisions from being soaked in these. Having our edges of conjunctiva soaked in antimetabolites will delay the healing of these tissues, causing wound leaks in the future. If the leak is tiny and IOP is not too low and AC is formed, we may offer a conservative approach by withholding or decreasing the dose of topical steroids, applying topical antibiotics, suppressing aqueous production, and making sure that the eye is protected from trauma and patient eye rubbing. We may also opt to give bandage contact lenses in these cases. If the cause of the conjunctival leak is due to surgical error, because of a buttonhole, loose sutures, or dehisced sutures, we may have to resuture the patient. If the conjunctival leak is due to a large gaping conjunctiva, the leak is very brisk, if AC is flat and the IOP is low, we may have to resuture or apply fibrin tissue or cyan acrylate glue. If the glue or suturing isn't successful, we may have to perform bleb revision and conjunctival advancement. If we have an overfiltering bleb, and even if it's overfiltering and our APC is deep, we may consider a conservative approach by again withholding or decreasing the dose of topical steroids, suppressing aqueous production, applying antibiotic, giving atropine, and applying pressure patch with a torpedo patch or a Simmons shell. We may also opt to perform a transconjunctival scleral flap resuturing. This was first described in 2004 and is an effective treatment to raise IOP and improve visual loss from hypotony maculopathy and choroidal effusion. Here, we use a nylon 10-0 to make a single interrupted suture over the conjunctiva through the scleral flap, through the sclera, and out the conjunctiva. If all methods are unsuccessful, we may have to do a Bleb revision by reforming the AC with viscoelastic, reopening the previous conjunctival incision, and tightening the scleral flap with one or more additional sutures using a nylon 10-0. The most catastrophic condition which may occur due to hypotony may be due to which can occur is a choroidal detachment. Here we see a serous effusion in the suprachoroidal space. In mild to moderate cases, it usually resolves spontaneously. Thus, medical management may be warranted in such cases. We can just apply topical steroids, atropine, and sometimes systemic steroids. However, if the drop in IOP is significant and you see massive kissing choroidals, we should address the cause of the hypotony, which may be due to an overfiltering bleb, and then drain the choroidals. As in this case, we suture the flap, and then after which we drain the choroidals by making incisions around 3.5 to 4.5 millimeters away from the limbus. There are other late complications which may require Bleb revision or repeat trabeculectomy. We will discuss some of them in the interest of time. Leaking blebs are usually due to thin-walled blebs that are common with trabeculectomies with anti-metabolite use. Usually, these leaks can subside with conservative treatment. We can give aqueous suppressants, broad-spectrum antibiotics, and do patching and applying bandage contact lenses. If leaks are large and not responsive to conservative treatment, we can apply cyanoacrylate glue or 5-in tissue glue. We can inject autologous blood injection, and we can do Bleb revision as well. If leaks are large and not responding to conservative treatment, surgery may be warranted. In this patient, he was a post-trabeculectomy patient which we lost to follow-up and came back around 4 months after. Here, we saw him with his flap exposed and a conjunctiva retracted and opposed or has adhered to the sclera. So we had to very carefully do dissection subconjunctivally and try to oppose the tissues to the limbus as much as we could, considering that these tissues tend to be very friable at that stage. Here are the pictures preoperatively and postoperatively. Failing or failed blebs are mainly due to the fibrosis at the conjunctival and episcleral interface with a patent sclerostomy. Usually our options are needling with 5FU, Bleb revision, a repeat trab, or an insertion of a GDD. But there are factors we should consider after a failed trabeculectomy. We should remember what the duration is from the previous surgery. We know that the 4 to 8 weeks post trabeculectomy is very critical in making sure that our trabs work or function properly. During that time, we should be either removing sutures or giving antimetabolites for early signs of scarring. But if we see a patient for more than 3 months and then they have a flattish bleb and a very vascular bleb, maybe the signs of scarring has already set in, and we should try to reverse this or correct this by maybe giving antimetabolites and doing a Bleb revision. We should also look at the residual function of our trabeculectomy. If the IOP post-op may be the same as baseline or lower than baseline, with stable or no further glaucomatous damage, then we may opt to observe. Or we may opt to restart with ocular hypotensive drops, as this may be enough as evidenced by partial success rates in glaucoma trial outcomes. We should also look if the trabeculectomy can be saved. Careful gonioscopic examination to ensure that sclerostomy is patent and free from internal obstruction. We should also look at the conjunctival mobility, inflammation, and vascularization. We should also look for concurrent ocular disease which contributes to the fibrosis, scarring, and failure. These are either uveitis, conjunctival inflammation, lid pathology, or past ocular surgery. We should also look for the presence of risk factors for failure or high-risk cases. These are neovascular glaucoma and our uveitic glaucomas. If we are thinking and considering of repeating surgery, we should also consider the location of our previous trabeculectomy. If our previous trabeculectomy was at the 12 o'clock area, maybe the next procedure to be done will be at the superior temporal area, and thus maybe we should reserve that for a GDD. But if our initial surgery was at the superior nasal area, maybe we have space at the 12 o'clock area for a repeat trab, or maybe just altogether do a GDD at the superior temporal area. We should also consider the status of the conjunctiva. We should look for an area of healthy immobile conjunctiva and the level of inflammation of the conjunctiva. We should also consider the age of our patient. The younger the patient, the higher the risk for failure because of a more exuberant wound healing that contributes to early fibrosis and scarring. We should also consider the difficulty of follow-up and patient compliance. If the patient cannot follow up regularly, or you predict poor compliance with post-operative care, a GDD is preferred. We should also consider the visual acuity. The poorer the visual prognosis, the more I would lean towards a cyclodestructive procedure. And lastly, consider the target IOP. If you need a lower target IOP or greater IOP reduction, maybe do a repeat trabeculectomy or GDD compared to other procedures such as MIGS. So if you still wish to perform a repeat trab, maybe use a higher dose of anti-metabolites than your initial trab, or maybe opt to performing a glaucoma drainage device or a diode cyclophotocoagulation. In this study, which looked at the long-term outcomes of repeat versus initial trabeculectomy in open-angle glaucoma, they were able to see that eyes that underwent initial trabeculectomy with mitomycin C had a statistically significant higher cumulative success rate than those that underwent repeat trabeculectomy with mitomycin C. In this table, we looked at the repeat trabeculectomy surgical success rate compared to GDD and the diode cyclophotocoagulation. Naturally, GDD and diode had a higher success rate than the repeat trabeculectomy. In summary, in filtering surgeries, post-operative management may be more challenging than the procedure itself. Good preoperative evaluation, meticulous intraoperative technique, and appropriate post-operative management are mandatory for all cases for a successful outcome. Early complications should be noticed and actively dealt with. Long-term monitoring of blebs is needed to minimize the late complications, and we should always consider the risk factors when performing repeat trabeculectomies. We all want to achieve the ideal bleb, a low-lying diffuse bleb with reduced vascularity and reduced cystic changes, IOP in low teens, well-formed anterior chamber with tight conjunctival closure. Thank you for your time, and good night.
A very good day to everyone. I would like to thank the APGS for this kind invitation to speak on subconjunctival bleb-forming innovations. These are my financial disclosures. Conjunctival filtration surgery is something that's very familiar to us glaucoma surgeons. Trabeculectomy has been the gold standard glaucoma surgery for decades, and indeed can be very effective in lowering the IOP, but is associated with potentially sight-threatening complications, such as hypotony and Bleb-related infection. In recent years, new subconjunctival mixed devices have emerged, increasing our surgical repertoire. The Zen is usually implanted ab internal, while the PreserFlow is implanted ab external, and both devices protect against hypotony. Let us first look at the Zen implant. Zen surgery looks deceptively easy, but there's really more to Zen implantation than meets the eye. To get the best outcomes, there are many finer points and nuances that surgeons would need to master. It starts with the preoperative mitomycin C injection. Injecting mitomycin C too near the limbus would predispose to an anterior bleb. Hence, the mitomycin C should be injected intratenons at least 5 millimeters posterior to the limbus. I implant the Zen with intraoperative gonioscopy. When the injector needle approaches the angle, I put an indirect gonioscopy lens on top of the cornea. In this case, it is a Mori lens. I pierce the sclera just anterior to the Schlemm's canal and then complete the Zen implantation. The photo on the right shows the ideal location of the Zen, just anterior to Schlemm's canal. I was privileged to be involved in the Zen Phase 4 study when I was working at Moorfields Eye Hospital. We recruited about 200 patients in this multi-center study, and the mean IOP decreased from 21 pre-op to 15 at 2 years, with a reduction in medications from 2.7 to 1.1. Complications were infrequent and mostly self-resolving, though there was one case of endophthalmitis. So far, there is no prospective comparative study between the Zen and trabeculectomy, but this retrospective study did not detect a difference in the risk of failure and safety profiles between the two procedures. However, with success defined as specified IOP levels, more eyes which underwent trabeculectomy achieved IOP of 14 or below. Our study reporting the one-year outcomes of combined phaco and Zen in Chinese eyes showed similarly good results with IOP in the teens at 1 year and success rate of 0.8. In this paper, we were also the first to report the outcomes of Zen in angle closure eyes, and rarely iris occlusion of the implant can occur, though it is easily resolved by laser. We also reported the one-year outcomes of Zen implantation in uveitic eyes. Zen implantation resulted in a significant reduction of IOP and medications at 1 year. Remarkably, though most patients were on 3 or more glaucoma medications, as well as Diamox pre-op, 62% were medication-free at 1 year. However, we did report one case of Bleb-related infection in this study, and this was followed by an AJO publication reporting 3 more eyes with blebitis and endophthalmitis associated with the Zen implant, highlighting that this is a potential concern in all conjunctival filtration surgeries. The Zen has been in clinical use for several years and is now available in many countries internationally. The new kid on the block is the PreserFlow microshunt, which is made of a novel material called SIPS and is commercially available in Europe and in Singapore. Unlike the Zen, for which ab internal implantation is possible, the microshunt is exclusively implanted ab external. I usually create a large 8mm peritomy and perform a wide subtenos dissection to create a deep pocket. I use 0.4 milligrams per mil of mitomycin C and leave it for 3 minutes. And then remove the sponges and irrigate with copious balanced salt solution. Mark the sclera 3 millimeters posterior to the limbus, and then with the blade provided, make a scleral pocket. Enter the eye with a 25 gauge needle, and as you approach the limbus, change the angulation of the eye so that the implant will not be pointing upwards at the cornea. Insert the microshunt into the eye through the scleral tract previously created and tuck the fin firmly into the scleral pocket to prevent peri-implant leak. Unlike the Zen, this is a hydrophobic device, so flow through the implant does not begin spontaneously. And one way of initiating flow is to bend the device to create a negative pressure, which will facilitate aqueous flow through the device. And there should be a very slow trickle of fluid. You can see the aqueous flow more clearly with the fluorescein. Then place the microshunt underneath the Tenon's capsule, ensuring that it's not obstructed by any Tenon's tissue. Subsequently, close the conjunctiva with nylon sutures, and it is important to check at the end of surgery that Sidus is negative and there's no wound leak. And some may argue that this is not a mixed procedure at all because it involves conjunctival peritomy. However, it is certainly less invasive than a trabeculectomy with no need for a scleral flap or flap sutures. This study by Bartley et al. Reported the longest term data on the microshunt, showing a reduction of IOP to the low teens and 0.7 glaucoma medications required at 3 years. These results are similar to our 2-year Singaporean data, which we are writing up soon for publication. Preliminary results on an RCT comparing the microshunt with trabeculectomy showed that traps resulted in lower IOP but were associated with more complications. Notably, 0.2 milligrams per mil mitomycin C was used in this study, while 0.4 milligrams per mil mitomycin C was used in Bartley's and my studies, which could account for the lower IOP we encountered. Nevertheless, for patients with very advanced glaucoma who require very low target IOP, trabeculectomy is still the more effective procedure. Comparing the microshunt with the Zen implant, what are the factors which affect our choice of implant? The 4 main factors to consider are surgical duration, efficacy, safety, and glaucoma subtypes. Looking first at the surgical duration, ab-internal Zen implantation requires only about 5 to 10 minutes, while microshunt implantation takes about 30 minutes. So for patients who are medically unfit and who require faster surgeries, the Zen implant may be preferred. How about the efficacy? This retrospective case series comparing the microshunt with the Zen implant showed that the 2 implants were similar in terms of efficacy and success, and both had a high safety profile. However, the study was likely underpowered as it only had 41 eyes in each group. And though there was no statistically significant differences detected, the microshunt achieved lower IOP with less medications and had a higher rate of complete success. My data in Singaporean patients showed that the microshunt achieved lower IOP than the Zen implant, despite patients with the microshunt having more advanced glaucoma. So I tend to favor the microshunt compared to the Zen for patients with more severe glaucoma. The reported needling rate for Zen is also much higher than for the microshunt. And this is because the microshunt is implanted ab-external, hence it is less likely for the tenons to occlude the implant. If the Zen is implanted ab-external with conjunctival peritomy, the needling rate will also reduce. Let us now consider the safety of the microshunt and the Zen. Both implants have an internal resistance and protect against hypotony. Hence, they are likely safer than trabeculectomy, especially for eyes at risk of hypotony, for example, high myopes. However, Bleb-related infection is a concern. Ab-internal Zen is associated with unpredictable Bleb morphology, just like trabeculectomy. The Blebs can be nice and diffuse, but I do get some anterior and ischemic-looking Blebs. Hence, the Zen has been associated with some cases of Bleb-related infection. On the other hand, the microshunt is a longer device and gives rise to a more posterior and diffuse bleb. As the device is implanted ab external with proper implant placement and conjunctival closure, the bleb morphology is more predictable. Because of this, my opinion is that the risk of bleb-related infection is higher with the ab-internal Zen compared than with the microshunt, though of course it is possible with both devices. Lastly, both the microshunt and the Zen are only approved for POAG. As discussed earlier, there are some small studies reporting the outcomes of the Zen implant in angle closure eyes and in uveitic glaucoma, but these are off-label indications. Ultimately, we require more data for the outcomes of these subconjunctival mixed devices in other glaucoma subtypes. In conclusion, subconjunctival mixed devices are potentially capable of achieving lower IOP compared to trabecular bypass procedures. And though subconjunctival mixed devices are associated with less complications compared with trabeculectomy, bleb-related infection is a potential concern. Thank you very much for your attention.
Thank you very much, Rainier and Chelvin, for excellent talks. So now I would like to open the next second Q&A question. We have one question from the audience for Rainier. So how many needlings you would do before the bleb revision?
Hi, thank you for that question. There's actually no hard and fast rule on how many times we can do needling. So I guess the answer is it depends. It depends on how the patient heals from the surgery. So we have to look at the bleb, the vascularity, the encapsulation, and we start from there. If we do see that there are early signs of failure, if you do see that for some reason there's some early encapsulation or bad vascularity that you cannot answer with topical steroids, then maybe we can do anti-metabolite injections early. But there are some patients which will need a lot of injections, and there are some which will not. So it actually depends.
Sometimes, normally we did the needling once and with a 5 injection, and we look for some improvement the next the 2 or 3 days after. So it means that how many 5 injection or how many needling you can keep going before you open up again and do the scar tissue removal or mitomycin C application in the bleb revision.
Actually, with the advent of the use of Zen, and there was a time when they actually suggested that we do a little bit more anti-metabolite injections to reduce fibrosis over where the Zen ends, or to reduce encapsulation over the bleb area. I think people started doing a little bit more anti-metabolite injections or the use of mitomycin as injections compared to applying sponges for their trabs. So I think people started to become more brave when it comes to anti-metabolite injections. So although I cannot say that for sure for a lot of the older generations, but I do see that among the younger glaucoma surgeons who practice MIGS and such.
So I also have a question for you, Rainier. So, for example, you see a patient will fail trabeculectomy with very scar bleb. Would you go for next step would be the bleb revision or the second trabeculectomy?
To answer that question, I would actually need to see if there is a chance to resurrect that bleb. So if there are some signs that the bleb is actually still draining, maybe doing some needling with anti-metabolite, aggressive needling and aggressive scar removal with your needle or even with an MVR blade needs to be done to try to open up some area. But if you do have extensive scarring that will not be able to be removed by a needle, maybe it's worth to do a bleb revision um, instead. You actually can do some testing with for checking the mobility of the conjunctiva above where your bleb is. So if you do see that there's not a lot of mobility, not a lot of movement in the area where your bleb is, then maybe it's a foregone conclusion. So there.
Do you use any imaging like anterior segment OCT to assess evolution before?
I don't have a lot of experience using anterior segment OCT on blebs or encapsulated area, so maybe some of the other panelists can answer that.
Maybe Chelvin, you have some comment?
You're muted, Chelvin.
Sorry, could you repeat the question again? Because there's a bit of a lag.
Yeah, sorry. So I did try to image my blebs from the Zen implant and from the micro shunts, and I find that yes, indeed, the OCT can show me which blebs are encapsulated. They have a very well-defined capsule around the bleb cavity. But similarly, I also find that clinically you can tell that as well. So I'm not sure what additional value the bleb imaging would result in. I've tried to do some OCT angiography on bleb morphology, and I find that for some of the scarring blebs, they do have much deeper vessels compared to some of the healthier blebs. So that could be an indicator that the bleb is scarring up if there's a lot of deeper vasculature within the bleb, and you may want to keep the patients on a longer duration of steroids or even to try anti-metabolites.
Thank you, Chelvin.
There's another question from the audience regarding to the bleb morphology. What kind of bleb morphology is appropriate for bleb revision instead of needling? Rainier, maybe you can answer that.
Okay, thanks, SK. Like I said, if your blebs tend to be really, really scarred, very immobile, or say you do have highly elevated, or even the small cystic blebs which tend to not drain or with very high IOPs, then those may be very good candidates for your bleb revision. I must say there are also we tend to see some blebs which tend to become very vascular, and we try to treat them with a lot of topical steroids to reduce the inflammation. These are early and bad signs of impending reasons for your bleb to become scarred in the future. So I think earlier treatment and being able to manage these early signs are more important than actually doing the later surgery for these cases. If we can prevent the later scarring, then maybe we don't need to do the surgery all along. So I think that's a better take on that.
Yeah, I agree with you, Rainier. And also, I think if the bleb is encysted, the needling will work. But otherwise, if you find the morphology of the bleb that is scarred, I think is unlikely that you can probably save it. We do have questions for Chelvin. Would it be better for Zen to be implanted ab external if it decreases the needling rate? And in relation to that, also, do you do open conch insertion of Zen nowadays? Or I mean, I'm hearing Ike Ahmed now advocating open conjunctiva.
Yes, thank you very much, Dr. Fang. So I think that's a great question. I think we all started out wanting to have the very elegant surgery of the Zen implantation. And to be fair, I think there are some cases that turn out quite well. It's just the predictability of it that is difficult. And how do we always get the predictable, nice, diffuse posterior bleb? That's the problem. I find recently, that, just opening up the conch and placing implants very reliably underneath the conjunctiva and making sure that it's not occluded by tenons gives me the most predictable outcomes. And that's why I tend to favor that now.
And another question from the audience is, why not inject mitomycin rather than using sponges for pressure implantation?
Thank you very much for that question. And in it as well, I think that it's easier to put the mitomycin C via injection and to leave it, or you can, even when draping the patient, you can inject it and can save time in the OT. But I prefer to put it on sponges actually, because I find, again, the positioning of the micromycin C is more reliable. While with injections, unless you're very certain it's underneath the tenons and doesn't get to the anterior part of the eye, near the limbus, which can predispose to anterior bleb, I think putting it on sponges very posteriorly and over a wide area gives better bleb morphology in the end, in my hands.
One more question for you, Chelvin. What is your advice to younger glaucoma surgeons who have just started trying subconjunctival devices? What is the learning curve, and what would the beginner expect?
So I think the first thing for younger surgeons is to learn from the gurus like experienced trabeculectomy surgeons such as Dr. Fang, Rainier and Dr. Dotan, who have many polls about how to manage the conjunctiva during these surgeries, because the same principles apply. You need a wide subtenons dissection. You need to close up the conjunctiva well. All these are surgical techniques that still hold true even with the new devices. I think what is maybe easier with the new devices is that you don't have to worry so much with long-term hypotony. For the Zen, sometimes we get early hypotony, but they often resolve, within a couple of weeks, even without intervention. With the PreserFlow so far, I really haven't encountered much hypotony at all, even in the earlier period. The other thing I would caution for these new devices is the implant placement, because we are always very concerned about the cornea. So with the Zen, with the very wonderful Mori lens, you can place the implants reliably, just anterior to the Schlemm's canal and posterior to the Descemet's membrane, and therefore not injure the conjunctiva. With the PreserFlow, you're going ab external. I think it's a bit more difficult to predict your entry location. So I would check also with the Mori lens after insertion that it is posterior to the shore baseline, that is not within the cornea itself. And if it is, I will reposition it before the end of the surgery.
Thanks, Chelvin. Rainier, I saw in your video your drainage of the choroidal effusion. Isn't it a bit anterior? I mean, you put your incision, you mentioned 3.5 to 4.5 millimeter from the limbus.
I measure. Well, it depends on the eye. There are some eyes that are short eyeballs, which are more prone for effusion in there. So it depends on eyes which are long or short. But I actually do some small incisions, and then I try to enlarge it under the conjunctiva.
Dotan, any comments on that?
Yes, I also think that we should drain the fluid a little bit far away from the limbus, maybe 6 or at least 6 millimeter from the limbus. I have a question also for all of you. You excise the thick tenon tissue in trabeculectomy or even for devices, subconjunctival devices, because sometimes the excision of the tenon tissue can cause a lot of bleeding. So it's not good for the future bleb.
Rainier, you want to answer first?
So the question is, do we excise? If I do decide to do bleb revision and I encounter a lot of fibrosis, then yes, I will most definitely excise the tissue. It's actually, it'll be actually very useless if I'm able to expose the sclera, make a flap, and then have a big Teno's fibrosis on top of it. It's just going to be a hard area on top of where your scleral flap is, and then eventually it's just going to scar again. If you look at the study which I showed, success rate will be low from 32 to 52% only for repeat trabs. So following that, if we think that our hands will be better than the hands that operated previously, that might not be actually true. I mean, we're trying to outdo somebody who should have done a better job. So maybe if there are some signs of scarring over the conjunctiva, over where the flap is, then I would excise it, and just making sure that I do not harm the conjunctiva or cause any buttonholes, as it may actually do a lot of harm in the future for the patient.
Yeah, I normally do not try. I mean, I normally don't excise tenons because I try to preserve the tissue as much as I can. How about David or Chelvin?
Yeah, Dr. Fang, similarly, I don't tend to excise the tenons. With the devices, I would actually advise caution with excising the tenons because that can lead to implant exposure for some of the surgeons who perform tenonectomy. Yeah, and I think if the tenons, if the device is placed very well under the tenons, it can also have a good outcome.
Yeah.
So even for the young patients, less than 40, with very thick tenon,
Yeah,
you don't.
No.
For the young patients, well, I haven't excised the tenons, so far, but I agree with you, there is a risk of scarring. If I were to do so for a young patient with an implant, I think I would make an effort to sew down the implant so it's not sticking out. Perhaps there'll be less risk of exposure.
How about you, David?
I would agree with both of you. I don't routinely excise tenons tissue, and being from the Keith Barton School of Glaucoma, I'm a pretty keen tube surgeon anyway. So if the trab fails, I'm going to put a tube in quite quickly.
I think I share your opinion, David.
Yeah, I don't believe in faffing around with the blebs too much.
Yeah, Dotan, and any last comment?
Because that will be very sometimes it's very harmful because for example, you put a tube in a young patient and it's all around, scar around, and you open up the bleb and see that the tenon, tenon will be 1 millimeter thick. So I think sometimes we should excise the tenon tissue when it is very thick and apply the mitomycin C after the tenon tissue removal.
Okay, one last question from the audience. How to diagnose malignant glaucoma is if UPM is not available? Maybe Rainier and Dotan can answer that.
The diagnosis of malignant glaucoma is based on two sides. And the first of all is the flat anterior chamber with very high IOP. And the second side is you have to exclude the subchoroidal hemorrhage with ultrasound B scan.
Okay, thank you, Rainier.
Yes, I must agree. We do need to exclude some of the other causes of high IOP in patients with a shallow anterior chamber. So clinically that may be apparent, or maybe making sure that you do examine posteriorly, look at the retina and see for any signs of things making the anterior chamber shallow.
Thank you, love. Thank you for all the questions and the discussion. I would like to announce that we will have last few slides after this Q&A. So just do stay online for the last few slides.
Sometimes I don't want to feel those metal hands. Yeah, it's like cranes in the sky.
So in closing, I would like to thank all the speakers for their excellent presentation and talks, and also the excellent discussion online. We do have the last webinar for this year on Saturday, 11th of December. So do join us on Saturday, 11th November for a webinar on probably glaucoma imaging. And lastly, I would like to invite all of you to come and join us next year. Can I have the next slide, please? In Kuala Lumpur from 5th to 7th August 2022, and hopefully we can meet face-to-face in KLCC. So I do hope to see all of you next year. And again, I would like to thank Santen for sponsoring this webinar, and also Professor Dotan for co-chairing this webinar with me. Thank you all for your kind attention, and also to the MCI team for excellent AV and excellent organization of this webinar. See you all next year.